I want to welcome you all. Thank you so much for coming to join us today for the next steps for lung cancer screening, building a more equitable program. I'm Christian Finley. I'm a thoracic surgeon here at St. Joseph's in Hamilton at McMaster, and I'm going to be the chair of the session today. And I think relevant to today's program, I'm also the clinical lead of lung cancer screening for Ontario. And I also am an advisor on the Canadian Task Force investigating this subject. But I think also very important to this meeting, I'm also privileged to serve as a member of the Lung Cancer Canada's Medical Advisory Committee. And I work alongside some of Canada's most committed clinicians, researchers, and advocates to drive innovation and change in lung cancer screening. And I think today we're blessed to be joined by a number of fantastic clinicians and researchers from across the country who are going to help us to better understand lung cancer screening in its place. Next slide, please. So, I think with that, before we begin, Lung Cancer Canada and myself would like to do a land acknowledgement. I think to acknowledge that our work and efforts today take place on the traditional lands of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and to all the lands where are now home to diverse First Nations, Inuit, and Métis communities. And I think in particular, when we're talking about lung cancer, it's important to acknowledge and remember that our commitment to lung cancer must reach all Canadians, including those Indigenous communities who continue to face a disproportionate amount of lung cancer in their lives. So today marks the launch of the Lung Cancer Canada's Policy Forum Series and aligns with the newly launched advocacy strategy and supports its 5 key priorities. Through these forums, we aim to address the barriers in lung cancer care and identify practical, actionable steps to support our core mission to ensuring that every Canadian impacted by lung cancer has access to care and the resources they need. Today, our focus is on identifying specific barriers to effective lung cancer screening and exploring how we can create a more inclusive and equitable approach for all, especially for underserved and marginalized communities. Our objective is to advance equity in accessing lung cancer screening, and this conversation is an important step in translating our advocacy priorities really to meaningful and impactful action. I'd like to thank each of our esteemed panelists who have joined us, and I'll introduce them each as we come to their talk. But each of you brings in invaluable expertise and dedication to this discussion. And I'm confident that we can create pathways to a more accessible and effective lung cancer care. Thank you all for your important work. To get things started, I'd like to set the context by providing a national overview of the current state of lung cancer screening in Canada, as well as progress and challenges lung cancer screening in Ontario, and how we expect this to evolve in coming years. All right, so this is a picture of my grandfather, my father, and I. My grandfather was a thoracic surgeon, my father's a thoracic surgeon, and I am a thoracic surgeon. So I'm a 3rd-generation thoracic surgeon, and I sometimes like to contextualize lung cancer care through the lens of my family, where when my grandfather was practicing thoracic surgery, 60% or 50 to 60% of Canadians smoked. We had a chest X-ray, and we really had minimal other diagnostics or therapeutics to help patients. And when you transform through my dad's era, that's where we started to get chemotherapies, CT scanners. And nowadays we've got incredible new innovations of lung cancer screening, fantastic medications, and I think we're going to explore a lot of that today. In terms of my talk, I'm briefly going to talk about the background of this, look at our current state for lung cancer screening and the progress and challenges we've had in Ontario, and where I see us making progress, and I'll really set the foundation for the rest of the speakers. Certainly lung cancer, when we look at it between different sites, is a cancer that presents at an advanced stage far more frequently than anything else. It's responsible for more death from cancer than breast, prostate, and colon combined. And yet receives only a fraction of that funding. And yet lung cancer screening is regarded as really a generational opportunity to change that survival, and has been shown in multiple large trials to improve survival by 20%, which I would put you is one of the bigger health interventions available to us. But when we look at funding for lung cancer, while it's responsible for 25% of cancer deaths, it only gets 7.3% of funding. And if you compare it to breast cancer, for example, it gets $21 million, to breast cancer, $62 million a year in research in Canada. And so we don't experience this equitably. In a report I put out with regard to lung cancer equity, we really looked and saw that lower income patients are far less likely to survive lung cancer than those that are more wealthy, and far more likely to present at an advanced stage. That we know that people who are lower income are twice as likely to be diagnosed with lung cancer, and those that live in rural and remote communities are also more likely to be diagnosed with lung cancer. But unfortunately, when we look at the multiple hits these people take along the road, they are more likely to smoke, more likely to get cancer, less likely to get curative treatment. They have a 25% reduction in survival compared to their peers. And when we look really at surgical resection, which is the backbone of cure for early stage disease, we know that the more impoverished you are, the less likely you are to get curative surgery for stage 1 lung cancer. When we look at our First Nation, Inuit, Métis, and urban Indigenous populations, we know that they're 35% more likely to survive less likely to survive lung cancer than their peers. And really, again, this is a multifactorial undertaking. Specific to Ontario, we looked at it and found, again, a significant reduction in mortality for our First Nation patients. So how do we make progress? Because I think we can all speak to problems, but what we all like to look at is how we can do better. Certainly in the Canadian strategy for cancer control, we can see that lung cancer screening is a priority in the country, and that's good that we have it. When we look at how far we've come, I think I've missed a slide there. We have a screening program in British Columbia, which we're going to hear about. Ontario has a program that's expanding to cover the whole province in the next 2 years. Nova Scotia has announced a province-wide lung cancer screening. And really in the other provinces, we have some degree of uptake that we're going to hear about today, but in many provinces, that's only a pilot and the funding is tenuous. When we look at the calls to action from the World Health Organizations, I know I was talking with Andrea Bowie, who's in charge of non-communicable diseases there, and really it's a call for reduction of 30% in mortality. And we see to get there for lung cancer, when we plotted it out, that really the bulk of that improvement falls on the backs of lung cancer screening, that about half of the improvement in survival we anticipate to get in lung cancer comes on the backs of accessible lung cancer screening. And the next largest portion is really equity. From an Ontario standpoint, we now have 5 sites that deliver it. Obviously, it's a huge geographic region, and geography is such a barrier to care. That when we looked at when we went from a pilot to a program, we evaluated how we were doing, and we were able to evaluate a large amount of people. Ontario, like many other of the provinces, have a 2-step process where we ask a broader group of people to come in, ask them some questions with regard to their specific risks, and then screen those with a high-risk population. So we're able to identify and recruit a large number of patients, that we're able to identify a proportional amount of Indigenous people, though I would say that we should have had more than the proportion of the population in Ontario just by smoking rates. And therefore, we're committed to improving our access to our First Nation Inuit Métis people. When we talk about smoking cessation, almost all the programs have opt-out programmatic smoking cessation, for which Ontario has been effective. But as you'll see, the quit rate is 10 to 20%, which I think is in alignment with the literature, but of course something we'd like to see that's higher. That we've realized that by doing that 2-step process of evaluating risk, we're able to do better than the clinical trials that this is built upon. And I think that's why worldwide that's been the pattern of undertaking it. That we're able to identify early stage disease, certainly more, and we found more cancers on the first scan than follow-up scans. But there's other things that we find. We call them actionable incidental findings that behoove us to be systematic about how we evaluate this and be part of a program as opposed to doing this opportunistically. That we realized that the barriers to geography could be mitigated by bringing care closer to home. And so the current approach in Ontario is to use a spoken hub model to get all the CT scanners in those small little communities up and running, both to offload the volume, but also to bring care as close to home as possible. And that people were satisfied with it. People were happy with how they were treated with respect, and that this was an effective way to deliver the care. And so I think from an Ontario standpoint, it's been a highly successful undertaking. And I think one of the worries was that this was going to overwhelm our system. And really, in our pilot, we found that it only represented about 3% of scans. And because they're non-contrast and can be done off hours, it really didn't affect anybody else's access to care as well. And so it is absorbable in a single payer system. And so what does the future hold? Well, we're going to need resources and funding. I think hopefully our speakers today can help us get us to that conversation. And we're at a unique opportunity where tobacco companies are paying out a huge landmark settlement. And so I'd like to see a large portion of that going to lung cancer patients and the community to develop an action plan. And so that really is the end of my presentation. And I'll pass this off to our next speaker, but I'm looking forward to having that conversation with you today and in the future. Our next speaker is Dr. Stephen Lamb, who is a distinguished leader in lung cancer research and early detection. And really, if you ask anybody in the world about lung cancer screening and mention the word Canada, Dr. Lamb's name comes up, certainly as far away as Perth, Australia. That's true for me. He's at the developing, advancing lung cancer screening. He's a world leader. And I think his strong effort is one that we've all recognized and appreciate his leadership. And so a luminary in this field. So without further ado, Dr. Lamb.
Good afternoon. So thank you for having me to take part in this forum. Next slide, please. It don't seem to be okay. I don't seem to be able to apply the slide.
Oh. Are you able? Yeah.
Okay. Can I have the previous slide, please?
If you just use your arrows on the keyboard, Dr. Lamb, you should be okay.
I don't. Okay. So we're going to talk about three things. I'm going to give a brief overview of the BC lung screening program to highlight some of the progress we made since implementation, and some of the things we do to overcome barriers in accessing screening, especially underserved areas. And then finally, going to talk about some of the things we do in research to broaden the screening eligibility to further the equity. So we have done two pilot study before implementation of the province-wide screening program. The first pilot study was done in 2008 as part of the Pan-Canadian Early Detection Lung Cancer Study involving 8 centers across Canada from coast to coast. And then in 2016, we were part of the International Lung Screening Trial. And then in September 2020, the province announced a phased rollout of a province-wide screening program. So in May of 2022, the first of the 5 health authorities went live. And then by November of 2022, all 5 health authorities began screening. And in May of last year, we have all 36 sites operational. I just want to pay tribute to our late Premier John Horgan, who just died a few days ago. He was instrumental in implementing lung screening in British Columbia. And I think through his efforts, we were able to start in BC. So my screen seems to be frozen. So the BC program is we use a centralized program workflow. This allows us to standardize our policies and procedures and have consistent and timely data collection and reporting. So the way that the pathway works is that the primary care provider identify potential eligible patients who can benefit from lung screening. So they can call the program themselves, or the primary care provider can fax us a referral. We also accept self-referred people, but we need them to a primary care provider for attachment. So when people are contacted by the screening program, we have trained navigators to determine whether they're eligible for screening. So our screening criteria is of age 55 to 74, who have a 6-year lung cancer risk of 1.5% or higher. So if the program also explain to them what the screening is all about, and then if they're eligible, we organize a CT scan for them. So we have what we call a cascade screening program information system. So the program automatically generates a CT referral to one of the 36 screening sites, and the CT department in that site will contact the individual to come for screening, and the scans are read by the program certified radiologist when it is done. So the program then receives the CT report and generate a report to the primary care provider and also a separate letter to the participant. So we give them the next step plan, whether a 1 or 2 year routine follow-up screening, early recall CT in 3 months, or we organize a diagnostic workup referral for about 2 or 3% of people who required workup for a suspicious lesion for lung cancer. The program also routinely retrieve reports from the cancer registry so that we can update of all the diagnostic workup results, and we collect outcome data for reporting, quality assurance, and quality improvement. Next slide, please. So this is an overview of how we do since the program started until the end of October. A total of 22,000 people contacted the screening program. 75% of them are eligible for screening based on eligibility criteria, and 84% of them have their screening CT. So it's amazing that 14,000 people have been screened in British Columbia. So 86% of the candidates were referred by the healthcare provider for screening. The average age is about 65 years, and 48% of them have high school education or less. We also have 6% of Indigenous people take part in the program, compared to 2% in the BC general population in the same age group. And about half and half are male and female. Next slide, please. So currently, the lung cancer detection rate is 1.63%, using the 1.5% 6-year lung cancer risk threshold for screening. And the proportion of people with early stage 1 or 2 lung cancer is 74%, compared to about 30% or less in the general Canadian population who do not have screening, and very comparable result to what is observed in Ontario. Next slide, please. So how do we access spatial inequity to lung screening? Before we start the screening program, we do a geospatial mapping to see how lung cancer patients will access one of the 36 screening sites. So because accessibility is a very important barrier to health service delivery. So what we found is 70% of the lung cancer patients are within 20 minutes of driving to one of the screening sites, 92% within 1 hour, and 8% over 60 minutes. So we still have to work a little bit on the 8% of people who have difficulty in accessing the screening service. Next slide, please. So our target is screen everyone within 60 days, but as you can see, the variation between the health authority. 3 of the 5 health authority, 80% of them are screened within 60 days, but because of limitation in CT scanning capacity, a little bit slower in some of the health authorities. Next slide, please. And this is not a unique program to British Columbia. If you look at the OECD countries and the CT scanning capacity in Canada in general, we are in the bottom 15% of all the OECD countries in terms of CT units per million. And then lots of our scanners actually are very old, 3 to 10 years old. And if you look at how much we use the CT scans, we're actually in the top 45%. So that means we're maximizing our CT scanning capacity for any imaging study and not just for CT screening alone. Next slide, please. So On the average, all the CT units are already used 14 hours per day, and about 80% of the sites actually using the CT scanner on weekends, and 40% are working 24/7. So to overcome the limitation, I think we need to have more capacity for CT screening because it's a very fast scan. Takes a minute to do the scan. It's not like inpatients. Next slide, please. So one problem we need to address is unattached patients. As we know, we experience a shortage of primary care provider. So the program work with primary care providers or clinics who accept referral specifically for management of additional findings, like people with cardiovascular risk assessment when we see a coronary artery calcification on the CT scan. And then example of some of these contacts that we have made is the community health clinics, walk-in clinics, telehealth. For First Nations, they have a doctors of the day, so we can attach them to one of the doctors. We're also working with the ministry for billing number for the program for allow us to have direct referral to the specialist for diagnosis workup or referral. Next slide, please. So finally, how to expand the reach of screening? We're fortunate to have a breakthrough grant from the Canadian Cancer Society to fund 3 centers in Vancouver, in Toronto, and also in Laval. The study is headed by Renelle Myers in Vancouver and Regine Hong in Toronto. This is to look at how we can make use of what we call incidental lung nodules found on this imaging study. There are many imaging studies done across Canada, not for screening purpose, but for other purposes such as cardiovascular examination. And very often they are found to have a lung nodule that are not being managed. So what this program is all about is how to optimize and make use of these incidental pulmonary nodules to create an automatic fail-safe management pathway and ultimately integrate the screening program with the IPN program as well. So we can see this is a very high-risk population. In our first year of experience, 3.8% of those with lung nodules have lung cancer, and only 10% are actually eligible for screening based on the current criteria. Next slide, please. So I think I will stop here. Thank you.
Thanks so much for that talk. I especially with the geography in British Columbia, to centrally run it is such an impressive undertaking. I'm looking forward to discussing that in our back and forth later on. It's now my pleasure to introduce Dr. Simon Martel, who's a respirologist in Quebec Heart and Lung Institute and the leader of the Quebec Lung Cancer Demonstration Project. His research and clinical work focus on advanced techniques in interventional bronchoscopy and lung cancer care, and we're very much looking forward to hearing his talk today.
Oh, can you hear me? Yeah. Hi, everyone. So thanks for the invitation. I'm not sure I can. I can control the
Dr.
slides.
Martel, yeah, you're able to control the slides. Just use the arrows under. Yeah, there you go.
Okay, good.
Yeah.
Good. So just as, oops, sorry. I will show you a small history of what happened in Quebec about the lung cancer screening. So just to start with, in 2019, the INS, which is the scientific committee who was overseeing the development in healthcare in Quebec, has draw a report and recommends that the LDCT lung cancer screening be available and accessible. But before that, only on the context of rigorous evaluation. So this was just before the pandemic. So we were supposed to start in 2019 this evaluation, but we couldn't. But a little bit later in 2020, we were able to start this, the draw of the project, and thanks to the Ministry of Health, but also with the Canadian partnership for the funding for this. So the project was designed to see in a real context what would happen with the screening. So we draw the project with the help of Ministry of Health. The project was designed to be 3 years from 2021 to 24. We had one coordinating center, 8 participating sites. We were supposed to have 9 participating sites, but one of the sites was overwhelmed with the problem with the pandemic and was not able to participate in the project. So we chose to, like Ontario, we chose to screen people from 55 to 74 years old, people who had smoked at least 20 pack years, former or active smoker were referred, and we used a score of PLCO score of 2% or more. So this is the pathway. We chose to have only one coordinator, coordinating centers, as I said. So we accept referrals and also self-referrals. We have a problem also in Quebec with the access to a primary care physician. At least 1/4 of the population don't have access to that. So people were just asking to phone to the coordinating center. Then we do a phone eligibility of the criteria. We refer them to the smoking cessation also if they were active smoker. Then we send them, if they were eligible, to the closest site, CT site. All the CT were reported with the lung RAS system and with radiologists who were trained for that. Then the report was sent to the coordinating center, and we were planning the following annual scan or interval scan or referring to the investigation in designated center. So the incidental findings were referred to the primary care physician. And like I said, it's we have a shortage of primary care access, and it is a challenge in our program. So this is just a screenshot of the dashboard that we had. This is a screenshot in the summer 23. And just to show you that we started in 2021. At the beginning, the old pathway was the mean pathway was 110 days from receiving the referral until the report was and letter were sent to the participant, and we saw that this was increasing after in the second year, and this is still a challenge. So we analyzed the first 3,000 patients, and you can see the demographics of the population. We were able to reach the people with less income, so we were happy with that. One of the points that we show is we reach active smoker, but we don't reach enough former smoker. That's one of the aspects that we show in this project. But there was no communication campaign, only at the beginning and not after that. So this is something that we should address in the future. So you can see the first 3,000 participants, the results of the lung screening. The results were according to the literature, and 93 to 99% of the participants who had a lung RAS 3 or 4 went to their prescribed interval scan or to the prescribed investigation. And for the annual screening, sorry about that, 83% were done as prescribed. So this is according to the literature also. This is in the green spot that we wanted. So this is the report of the NFPQ, who was overseeing the project. There are many pages in this report, but I'm just showing the many findings of the early indicators in lung cancer screening that we can have. So most of the indicators were in the green range. We had a 1.6% detection, like almost like a BC, Stephen just showed, and also Ontario. And we also had the numbers of surgical biopsy or surgical intervention for benign disease was very low, which we were very happy with. So this is after 2 years, the lung cancer found in this first 3,000 participants. So we had 81 cancer, and most of them were in stage 1 and stage 2. So downstaging target was reached. but we had a higher number of patients treated with SBRT than expected, and 6 of them were treated without a diagnosis. So this is, so this can bring some reflection because we should at least screen people who are fit for surgical treatment, but this is a discussion that we're having here. So where are we now? We're in the expansion phase. We're still screening. The demonstration project is closed now, but the Ministry of Health was willing to keep on with the screening. There wasn't an official announce of a program, but we're allowed to expand. We're actually 16 sites. We started with 8 sites. And we're working with 9 more sites coming in the next 6 months. So we should be with 25 sites in the first half of 2025. This is a number of referral and self-referral we had in the first 3 years. So we have now more than 10,000 people screened in Quebec. But on the other hand, there was a significant increase in delay for initial LDCT access in some region. So we were able to reach many early performance targets, which is favorable to pursue lung cancer screening. CT scan access is a problem, and it should be specifically addressed. We were able to contain the utilization of resources with the standardization, but costs remain an issue, but seems to be in the reach of the public healthcare system. We have many challenges. So like I said, the CT scan screening availability. We also have the shortage of radiologists. So we have a problem sometimes with the reading delay. Smoking cessation, we were using the phone line, but we think we should find something to do better with that. Screening criteria is also a discussion that we have, but we decided in the last year to keep on with the same criteria for now. And it is also difficult to manage sometimes incidental findings with the primary care physician shortage that we have. So I'll stop here.
Well, thank you very much. That's a great talk. We're having a bunch of questions coming in, and I'm going to finish all the talks and then sort of stack the questions into the whole discussion period, if that's okay with people. So keep them coming in the chat, and that keeps a good record for me to make sure I address all your questions. But before, so we're going to head off to our next speaker, to Dr. So I should start by saying thank you, Dr. Martel. That was a great talk, and actually it's impressive to me that Quebec has got 18 or 19 sites and doesn't have a program yet, and Ontario has a program and only has 5 sites. And so I think that you're doing great work with what you have there. So I'm looking forward to having that conversation. Our next speaker is Dr. Alain Tremblay, who's really been in the trenches for decades, as far as I can recall, doing this. Ever since I've been involved in this, I know he's been well ahead of me, and is the medical director in Alberta for the lung cancer screening program and a professor there in respirology. He's really been focused on lung cancer for the vast majority of his career, and really does a lot of heavy lifting at West with regard to advanced bronchoscopic techniques, pleural techniques, interventional pulmonology, you name it. So I'm looking forward to hearing about the Alberta experience, and as I'm sure everyone on the webinar.
Well, thanks, Christian. I need to acknowledge Dr. Lam, because I was merely a bronchoscopist at that time when he roped me in to participate in PanCan. And people might recall that there was a autofluorescence bronchoscopy arm to that study, which is what got me interested. But it kind of started my path on the screening front. So thanks, Stephen, again for roping me in way back then. I think that was probably 2007. My slides are not advancing with my arrows. I don't know if someone can do that. Okay, so I'll update people on what's been going on in Alberta. Yeah, no, I can't advance. Sorry, next slide. We've just finished enrolling in a demonstration project, 3,800 people. So that, the last people are still waiting for their first scan. So it's still a very much active project. And we've now submitted a request to Alberta Health, the political arm of the healthcare system, for funding for an expansion towards a full-scale program starting in April, because our current funding ends at the end of this fiscal year. So we're eagerly awaiting a response to this proposal. Next slide. I'm going to focus a little bit on what we've done, maybe some of the little things that are a little different than some of the other provinces have done, because I think those are good things, to do things a little differently, because that's how we learn. If we all do it the same way, we'll never learn if we're doing it wrong. So a couple of things we've done, I think, different than the other provinces. We've started at age 50 rather than 55, mostly because of the evidence in the Nelson trial, where about 20% of participants were aged between 50 and 54. So we had difficulty excluding that group. And I think when you combine that with the risk model, the PLCO model, you really avoid screening, low risk young individuals, which is kind of the concern about screening younger folks. So I think combining the Nelson results with a risk calculator, you really identify people that remain at very high risk of lung cancer despite their younger age. We initially wanted people for the first phase of the pilot to have a family doctor, but we've had some direct referrals from individuals where they didn't have that, and we really put some resources into try to link them with primary care. But like in most places, there's a shortage of primary care providers. These individuals need primary care. They have risk for many other diseases. Really, it's not acceptable in the richest country in the world that we don't have primary care for people in this risk group. We used maybe a little lower calculation threshold from the PLCO model at 1.5%, and we used a 3-race model. I think if I'm not incorrect, the other provinces are using the no-race model. The 3-race model includes Indigenous status and Black Canadian status. We're all a little uncomfortable with those, mostly because the model was drawn from U.S. populations. And it's not completely clear if we can simply extrapolate that to Canadian populations. And I say particularly for Black Canadians, who in the U.S., African Americans have actually pretty bad lung cancer outcomes. In Canada, they actually have very, very low lung cancer rates, mostly because of very low smoking rates. So it's not a perfect tool for Canadian populations. But hopefully down the road, all of the provinces can combine their data, and we can come up with a Canadian version of the risk calculator. Next slide. The flow of the program is probably similar to what others have done and have reported on. Maybe something that's a little different is we embed a nurse practitioner in the program, and that allows us to troubleshoot when there's difficulties at enrollment, some unusual questions perhaps that come up sometimes. And also on the results management side, it allows us to refer out very few patients that have findings. Essentially, unless you really need a PET scan or something more, you don't leave the program. So our nurse practitioner can do a phone interview and keep people within the program. And I'll show you the referral rates in a second. Next slide. We've developed some patient resources that are on our website and are provided to family doctor's office as well. Next slide. We've translated some of them. We're going to keep doing that work over time. This is an interim report we did in the spring to go along with our Alberta Health submission. Again, at that time, we enrolled just over 3,000 people. We had really good completion rates after enrollment of 87%. Our lung RADS finding were as you would expect. Next slide. A recall rate about 10%. Maybe go back one quick. And the referral rate is 3%, so that's quite low. I think most other publications are more in the 6 to 10%. And again, that's just because of our nurse practitioner that's embedded in the program. Our lung cancer so far are heavily shifted to early stage at 82%. which again is what we of course want to see. We're starting to get our annual data, annual follow-up data, and again at 85%. We're quite pleased. I think the Ontario and BC have had, and Quebec as well, similar numbers, which is great to see because as you know, the US numbers have been dismal with, you know, some places showing single-digit follow-ups at 1 year or in the low teens. So clearly the way we do it in Canada with a more centralized approach seems to work a lot better than maybe the ad hoc approach used in the US. Next slide. We have a provincial electronic EMR, which is really nice for provincial programs like this. So this dashboard gets updated on a weekly basis so we can get real-time data on our program. So this is still being tweaked and improved, but it's been really nice to have easy access to our program data and on an ongoing basis. Next slide. We did test out a self-referral. I think everyone wants to have a self-referral option for people. So we're really interested in that. We started that last winter. And in particular, we developed a web portal where individuals, as well as family doctors, but targeted to individuals, can do their own risk calculation and then enroll in the program. And then a nurse calls them if they're eligible and confirms everything, and then orders the CT scan. So we're very interested to see how that works, and we have some preliminary data there on the next slide. You know, and one of the things we're trying to test is, you know, how accurate are people in submitting and doing their own risk calculation. Next slide. This is what it looks like. So they're the basic PLCO questions. There's a bit of instructions that we've built around that. There's some logic in there so that you know, unlikely numbers or answers get rejected or flagged. Next slide. And then at the end, they get their risk calculation. So for example, so for the patient portal, it doesn't give the actual number. It just says you know, you're high enough risk that we would consider screening. You know, for us, it's 1.5. It doesn't get into the actual number. And if they want, they can either call us at that point, or they can actually put their number and their information, and we'll give them a call back and confirm everything. Next slide. The family doctors can also do this. If they do it with their patients, they get the number, the percentage. Next slide. And then they can actually just print the referral form, which is great because then we get it as a fax with all the information for the risk calculation already there. This is our data that we're hoping to publish soon, where we looked at the agreement between what the individual put on the website and what the interview with the nurse on the phone, how well they correlated. And you can see that for each of these items, there's very, very high correlation, usually above 95% between what was obtained by the nurse and what the patient put on the website. You know, for some, you would hope it would be 100% like age, but, you know, it's silly, but sometimes they've had a birthday in the 7 days between the two calls. So sometimes there are explanations like that. So very high accuracy. That being said, in almost 1/3 of entries, there was at least one discordant answer, and that can impact the risk score. So we do think this web entry does still need to be validated by a healthcare professional or someone trained to ask the questions to make sure that it's accurate. And in some cases, it did switch people from being eligible to not eligible. Now that was only in 3 or 3.5% of cases. So in most cases, the web entry was accurate in determining eligibility. Next slide. So this is basically what I just said. The other thing we realized is, you know, if they were just under 1.5%, we never called them. So it's possible that we missed people that were, you know, just below on the website, but in fact, because of an error, we're just above. So we're gonna be looking at maybe calling everyone above 1.3%, for example, or 1.2% to make sure we're not missing people and get to confirm their eligibility. And then, yeah, the field logic is very important. You know, sometimes people put their weights in kilograms instead of pounds, and it kind of messes up the whole thing. So you want to make sure the website is well developed to reduce spurious data and have really good information and instructions for the individuals to fill it out properly. Next slide. So as I mentioned, next steps, well, unfortunately now we're close to enrollment, so it's really been disappointing. We've had to tell all of our family doctors after 3 years of engagement to stop sending us patients. So we're actually quite sad about that. But we hope that's a short-term situation. Like I said, we're eagerly hoping for an announcement shortly from Alberta Health. Hopefully it'll be a positive one. Recently, the province has actually announced funding for a mobile CT for lung cancer screening, which was really a surprise to us because we don't have funding for the program to actually use it. So maybe that's a good sign, and it's just a bit of a sequence problem in terms of the announcement, but we're taking that in stride. And if we do have a program next year, the good news is we might be able to reach some Albertans either that are far away from current CT units, or maybe use a Manchester model where we actually go to urban areas that where patients are more likely to show up rather than coming to the hospitals, which people don't necessarily like to do. I think that's the last slide. Thank you very much.
I must congratulate all of our speakers who have stayed on time. So you're all getting gold stars from me. So that's good, well done. There's a number of fantastic questions, which I'm really looking forward to having a conversation about. And I'm not ignoring you. I'm trying to answer them where I can. But there's up and coming conversations on AI and never smokers. I have a list going. All right, to our next speaker. So thank you very much, Dr. Tremblay. That was wonderful. With regard to our next speaker, Dr. Geoffrey Liu is a medical oncologist and senior scientist at Princess Margaret Cancer Centre in Toronto, and is just a profoundly productive researcher with over 350 peer-reviewed articles, which I'm just so impressed by, because each one of those takes about 90 hours to generate typically. So you can imagine how many hours he's put into bringing this literature to us. But he's going to speak today really about leveraging the data for equity. So I'm looking forward to that talk.
Thank you very much. I think I also have a problem with the arrows, so I'm just going to say, please advance so we can keep on time. Thank you. Next slide. Okay, so equity really means that if you have a similar high risk for lung cancer in Canada, there should be an equal opportunity to screen for lung cancer. So where we might have some issues is that, some patients might be declared currently eligible by the current criteria, and yet due to things like geography, logistics, or culture, might not be able to have an equal opportunity for screening. But there's also another group, like those individuals that are not currently eligible, but could be at the same level or higher risk for lung cancer than the ones who currently are a criteria, or in some cases they just haven't smoked enough in order to qualify, and yet they're still at a reasonably high risk. So I'll cover some of these topics in the few minutes that I have. Next slide. So I think Ontario's hub and spoke models and the models that have been developed in BC are already a major advance to kind of dealing with equity issues. And you've seen that in the data that's come out with the a higher proportion of individuals with declaring themselves as being Indigenous, for instance, compared to the overall population. But there's still multiple barriers that still exist, either geographically, cultural beliefs, cultural safety, language, and inability to coordinate with existing care, and in some cases, this issue of not being attached to a family physician. Right. And we've already heard a little bit about a mobile lung cancer screening program. Right. And so in a way, that's this is not the only solution by any means, but that's one example where it could act as additional capacity to travel to different regions and address some of these equity barriers, and could be in fact complementary to an existing hub and spoke model, for instance. So I'll give a little data. Next slide. I'll give a little bit of data to support this. So there's been a traveling bus, if you want to call it, for dealing with breast cancer screening, which also covers cervical and colon cancer in some instances as well. And there's been at least a program in Ontario that's been operating for over 20 years now. And it's complementary to the existing Ontario breast screening program sites as well, too. And so there's some evidence to suggest already that this might be helpful. Next. Next slide, please. Thank you. Whoops. One back, thank you. So this issue of then, could this be useful in the context in Ontario, right? So it's very promising to hear that this has already been approved in Alberta, but in Ontario, it's a very large province. It's a very large population. So in this case, there has been a group led by Lung Health Foundation and also Healthcare Tech Together, and I'm helping them in terms of gathering data to assess the feasibility of this. Next slide. So with this in mind, some of the upcoming and current events include community engagement, as well as kind of building a business case to see if this might work in Ontario. And it would be very nice to have some data coming from Alberta to see how it's working in Alberta as well too. Next slide. Then we have the issue of the fact that, can we use digital health technology? And we see this in Alberta, for instance, where family doctors and so forth are actually putting in the actual data to find out if someone is eligible. Because in Ontario, a certain proportion of patients, are referred to the screening program, but they don't qualify because they don't meet the criteria. We can kind of reduce that rate in some way or another, perhaps using, as I said, AI technology or technology that's pulled from the electronic health record already. That might mostly fill a number of these questions and improve the efficiency, for instance. And so there are pilot implementation programs, for instance, in the Greater Toronto area that are looking at using this type of technology where we don't even need the family doctor to start off with, but pulls the data directly from the chart and then informs the family doctor, hey, this patient is potentially eligible for lung cancer screening. Would you like to talk to the patient at the next visit? Next slide. So then there's this issue, we talked a little about geography and logistics, but culture is a very important aspect of this. So in looking at the data from around the world, for instance, just as one example, the UK Lung Health Check conducted 6 focus groups with over 200 participants and found that some participants would put off if they heard the word cancer in the screening, some would not attend if it was in a hospital setting, some would or could not travel, and some would not engage into a program with the first point of contact with a doctor. So there are all these barriers that exist. It'll be interesting to find out how many of these exist in Canada, in what context, and if there are other types of barriers that are more cultural specific to Canadian populations or subpopulations that we need to explore. Next. And as an example, some of the work that Ambreen Solani has been, she's a person really focused on screening and diversity in this particular setting and equity. She worked with us at Princess Margaret and also at St. Michael's Hospital to look at this question of inner city underserviced populations and publish a few articles on some of the perspectives. And some of the things we learned was actually very dramatic. For instance, we didn't realize that in some cases, people had trouble going to the appointments because they were during the daytime, and they couldn't afford to lose time off work, for instance, or their employers basically wouldn't give them time off work, things like that. Next slide. And then this other issue of age, right? As we heard about from Alberta, from Dr. Tremblay, about the fact that they've reduced it down to 50 years old, but a lot of it is dependent to some extent on the populations you're dealing with. So just as a data example, lung cancer in the Maori in New Zealand is 3 times the incidence of that compared to non-Maori people, and occurs in a younger population in general. And in this particular case, we're kind of wondering, do we have any data on our folks in the First Nations, Inuit, and Métis populations? What about the inner city and the lowest socioeconomic classes, right? Is it possible that we have individuals that are lower than the current cutoff ages or have different characteristics that make them at higher risk at a younger age, for instance? Next slide. So, and there's a growing literature that actually publishes on this issue of everything from mobile screening to this concept of how do we do with equity in terms of doing CT screening in these underserviced populations. Next. But then there's another aspect to this, right? Because we already know that depending on which part of the country you're at, anywhere between 15% to 25% of Canadian lung cancers occur in lifetime never smokers, and another reasonable proportion of 20 to 30% at least will have smoked too little to qualify for screening, and yet had developed lung cancer. So if you actually were able to screen every screen eligible patient in participant in Canada, diagnose their lung cancers at an early stage, 100%, and cure all of them, more than 50% of lung cancers would still be not qualified for screening in this setting. So this is a big deal. And some of the data most recently coming out comes from, of all places, from Asia. So in Taiwan, they used low-dose CT screening in amongst never smokers and found that, in fact, the never smoking females, for instance, had a very similar rate of pickup of lung cancer as heavy smoking males in Western populations. So that's a group that we haven't really looked at, for instance. Next slide. But then comes to the idea of then what happens? How do we deal with the fact that there might be some never smokers and some late smokers that might be at risk? Now, it may be extraordinarily difficult. About an hour ago, I was actually speaking with Martin Tamamagi, kind of the person who developed a lot of these eligibility criteria and rules in screening, and he was saying that we need to enrich the population, enriched by about 12-fold. In order to have something that is cost effective, if we start with never smokers. So maybe we need to use some newer technology, things like, blood, for instance, which we call liquid biopsy, breathomics, where we breathe into a machine, or in order to actually identify individuals who are at high enough risk, that just figuring out their age and their ethnicity and all those things might not be enough by itself. And those are things that we're all looking into. Next slide. So one of the things that we're doing, and we know that the group in British Columbia is doing this as well with Stephen Lam and Renelle Myers and so forth, is trying to start some pilot programs for screening in high-risk never smokers. So our program is called SHINES, Screening in High-Risk Never Smokers. And we're looking for, right now, individuals of an East Asian background to start off with, because we want to show the highest risk individuals and the data that we have right now, and to show that we're meeting that 1.5% initial catch rate for lung cancer, and then hopefully expand it to other groups as well, men and a larger group of individuals that are at risk. At the same time, developing stratification and risk models. So in other words, surveys that will help capture who's at the highest risk in this particular setting. And we're mixing it in with looking at their bloods and also looking at their breaths in this particular setting. Next slide. And also, what we just got funding from Lung Cancer Canada, thank you, Lung Cancer Canada, and is a Geoffrey Liu grant, where we're bringing researchers and advocates and patients together in what we call the CLANS website, the Canadian Cancers of Lung in Never Smokers. In this way, have a forum to actually bring all these individuals that don't necessarily fit into the high risk, high smoking group, to actually discuss what we can do to work together in terms of coordinating everything from screening to treatment and management in these patients. Next slide. And so gathering these new technologies, I'm going to run through 5 very quick slides. I'm going to give examples of some of the technologies. Next slide. So we are actually taking blood in order to help generate, looking at the genetics that people can inherit, to see if that may help in terms of deciding who's at higher risk. Next slide. We're also looking at, I skipped one, but that's okay. We're looking at the circulating, that's okay, next slide, the circulating proteome. So in other words, proteins that are in the blood, to see if we can capture pulmonary nodules and also lung cancers. Next slide. We're also looking at the methylome, which is DNA from the tumor itself that gets leaked into the blood, to see if we can use that to detect. And our initial data suggests really good sensitivity and specificity. Next slide. And also using these tools, as well as working with the group in British Columbia, of actually having individuals breathe into a machine and then using that data to see if we can capture or detect early some of these cancers. Next slide. And finally, we're also looking to see with all the different scans that are coming through, Dr. Lam talked about this issue of incidental pulmonary nodules. So we're trying to also see if we can have clues in terms of what we see in terms of deciding which nodules and the imaging patterns of each nodules using artificial intelligence to decide which ones are more or less likely to become lung cancers in the next while, so we can follow them as well. Next slide. This is my final slide to basically saying that we need data in order to actually leverage for equity. And equity in this case means making sure that people who are eligible currently, get the best treatment, and also expanding to other groups that have a similar high risk, but we're not capturing them right now. And with that, I will stop. Thank you very much.
Well, thank you so much. That was a great talk, and I think it's actually acts as a great bridge into our conversation today. Really, we're going to this panel discussion for the next 20 minutes. There's all sorts of little symbols flying up. My kids, I'm sure, could also make all those symbols fly at the stage, but I'm quite impressed with all of our audience for their facileness with Zoom. Okay, so the first question I think that really jumps on the back of your presentation is AI. Clearly, one of our questions asked was about AI and its role for lung cancer screening, and I think that you've spoken quite elegantly to the utility in radiology of AI. And Dr. Lam, I know that you've done some work in that area, and so maybe if all of our panelists, if they would like, can sound off on where they see the role of AI in lung cancer screening in the future.
So maybe I can start first. I think AI is very promising tool to improve our ability to identify people at high risk. So to give an example, if you can look at a single CT scan and determine the lung cancer risk with or without a spot or nodule on the CT, then we will be able to identify people at high risk that may benefit from screening or further investigation. I think we are not quite there yet. I think, as Dr. Liu mentioned, we need to have a lot of data to do some better groundwork, because the imaging technology need to be defined better. We're using different scanners, different image reconstruction algorithms, and so on. It's different than publishing a paper, right? We need to have something that is robust that we can use in the general clinical settings. I think this is the work that we need to do.
Yeah, I think it's so to Dr. Tremblay, maybe I always sort of thought I can go to the airport and check in for my flight, and it allows me to fly across the country and I can enter my own data. But in healthcare, we sort of don't allow patients to participate in almost self-advocacy. I think it's really forward thinking of you allowing people to sort of pre-screen themselves. Have you gotten any pushback from that, or any sort of opportunities lost that you would sort of share with the group?
Yeah, I think the one thing we realize, as I mentioned, is we want to make sure we double check people that are maybe just below the cutoff. Certainly, it's one of the drivers for us was also that we're getting a lot of calls from people that was very low risk, and it was a nursing resource that was expensive. So we were trying to offload to either the family doctors, which in general haven't been super keen on doing the entire risk evaluation. It takes time. I think they can maybe offload it to some of their ancillary staff in the clinics in the future. But we thought, why not let the patient do it? And I think in general it's worked quite well. And hopefully we're going to keep tracking it over time and see how it gets used and make sure it remains a useful tool.
Well, I think one of our questions again jumps into how AI can help us with notes and note taking and sort of documentation of information. One of my colleagues uses it in her family practice office, and it sort of sits in the background running, and it'll generate a note on your whole conversation beautifully at the end of that conversation, which to me is such a time saver, and when applied well, I think will be sort of the best of technology.
And I think some of those screening things that aren't, I'm not sure that fall into AI, but certainly in the EMRs, people have described how you can have EMR flags, for example, and perhaps a more sophisticated one could actually do, pull any information from the EMR. But, we don't usually have discrete data fields for family history of lung cancer, for example, so then you need AI to actually look at a note, extract the data. But I don't think I've seen anything, ready to actually do that work, but potentially it could be done.
Well, I think to Dr. Liu's, Dr. Lam's conversation, there's just stuff gets missed, right? Like how many nodules are reported on all the CT scans we've done that nobody picks up on? If it's not in the impression, nobody cares. And so it has like it's something, somebody, some software, if it can capture all those missed opportunities, obviously will have huge impact. I have other questions, but I want to make sure Dr. Martel gets in here. Implementation, like clearly so much of this is getting it across the line. You know, BC just did, you know, I think to your point, Dr. Lamb, Premier Horgan is singularly responsible for just pushing it over the line in British Columbia. And I think that's helped the rest of us, I think, get a more realistic chance of implementation. But to Quebec, you sort of silently are being fantastic and not sort of, I think, getting the kudos that you deserve. Like you've got 19 sites up and running, you've done 10,000 scans. You know, you're crushing Ontario. We've been sort of loud and sort of talking about how we have a program, but essentially you haven't announced you have a program, but you're doing great work. How much of that do you think is like being clever by staying under the radar and not trying to ask for all the money and just getting the job done? Like how did you get it done? I think I'm sure we'd all love to hear. Oh, Dr. Martel?
Oh, I was on mute, sorry. We were lucky that the Ministry of Health was willing to letting us keep on with the screening. And we were able to capture, you know, at the beginning with the funding was hopefully a little bit too much, and we were able to keep the nurses in the coordinating center. So with the coordinating center, we were able to do much work than we were expecting to do at the beginning. And since the Ministry of Health was willing to let us implement more sites, we started to discuss with other sites in Quebec. We started with sites that were willing to participate, because some of the regions are, you know, they have major problem. Like I said, Outaouais, which is close to Ontario, they have a huge shortage of human resources and radiology tech, so they were not able to participate in the screening. But those who were able to start, we were willing to help them to implement the screening. And since the CT scan is in Quebec, the CT scan is, you know, paid for the hospital. It is paid per use. So if you do 1,000 scans, you will be paid for, the hospital will be paid for 1,000 scans. So it was more easy to implement the CT screening in these hospitals. On the other end, for the regions that don't have screening yet, it is because they have major problems. So they will probably implement CT when they will be forced to, with the official announce of the program. So we were able with those who were willing to, but actually those who are not able yet, we will have to wait for an official announce.
Because there clearly has to be good data and sort of, as you said, readiness on the ground level, but you then also need to have support from a high level. And so do you feel like that you were able to sort of expand and promote and keep going because you showed good work and that you found lots of cancers and you were doing good work, but also you had support from up on high? Or do you think it was, how did it, because there's some sort of magic recipe there that would love to hear how you got it there.
Yeah, in fact, the director of the oncology program in Quebec, the whole oncology program at the Ministry of Health is, you know, is a strong believer of screening. Mm-hmm. So this is one of the major point that helped us also. And he saw the results of we were able to do, so after 1 year, we had 3,000 participants. At the beginning, we were in the pandemic. They didn't believe that we would be able to screen 3,000 people in 1 year. So we did it. So they were very happy with that, and they saw the early results. So he was already a strong believer. So he helped us a lot at the Ministry of Health so we can keep on screening even if there's no official program yet.
Is that Jean Letray?
Yeah.
Yeah. So Jean Letray sits at a table that I've sat at. That's the Canadian Partnership Against Cancer. And so and CPAC has put $13 million into lung cancer screening just to try to get people up and running with the pilots. So how much do you think those conversations at that sort of high level, those sort of provinces where they say, oh, do you have lung cancer screening? Oh, we have lung cancer screening, helps to facilitate. Like Dr. Tremblay, like I can't help but think you've been slugging it out in the trenches since 2007 when Dr. Lam convinced you to do something. And he got an opportunity and was able to push it across the line, but you've been working tirelessly as well. Like there's got to be some, like, what do you think?
Yeah, I think our first proposal for a program was in 2016. So yeah, it's been a while of asking and being told no. So I've told people this is my last time I ask. It'll be someone else's job if they say no. But you know, I think having champions is very important. You know, Stephen mentioned Minister Horgan. You know, I think having a champion in Quebec in the ministry. And then, you know, the advocacy is so critical, you know, so that's where Lung Cancer Canada and other individuals and other organizations like that, I think, can have a critical role, because in the end, governments, if no one's asking for something, they're not going to go out and spend money. And as we know, with the stigma around lung cancer, you know, people haven't, you know, compared to other cancers, haven't been raising their hands saying, how come we're not doing this? You know, so we need more of that advocacy as well. And I think the CPAC has been instrumental, of course, as well. I would have loved to see, for example, as part of the large federal transfers to the province, you know, something like funding for NRT and funding for lung cancer screening, you know, rather than just diabetic medication, for example. But, you know, so there's lots of opportunities for different organizations to help the provinces make the right decisions.
Well, it's I want to get back to that in a second, because I do think that whole advocacy and because I think there's this generational opportunity, we need some money, and clearly big tobacco is coming up with a big cough up of cash, and we need to find a way to carve out a large chunk of that to realize the opportunity that we have right now. But I'd be a bad host if I didn't include all of my speakers. And so, Dr. Liu, I need to go back to some of the questions that are in there about changing risk. And I think there's certainly been some questions about, what about never smokers? What about, you know, if you do a bunch of CT scans and they're normal, can you stretch out the time frame? What about if I keep smoking? What if I stop smoking? What if I find it a first degree relative is a smoker? Equity, socioeconomic determinants of health. Like we are all a giant mosaic of risk. How would you see in the future us doing a better job of you know, taking account for an individual risk and personalizing their care? Because clearly we're in that era of medicine.
Yeah, I think it's exceedingly important. I think that's also where machine learning and artificial intelligence plays a big role in helping us figure out which characteristics and in what time frames. Already, some of the work that we've been doing with Regine Hung at the Lunenfeld Center next to us has been working through a global effort to try to figure out whether a blood protein marker could help determine whether we could stretch out from 1 year to 2 years or from 1 year to 3 years, for instance. So more data, more carefully crafted data with clinical implications, I think are probably what we're going to need in order to help us answer these questions. They're very important ones, and they can make a significant cost savings and make the system much more efficient, and we can just figure these things out. But it's going to take time and a lot of effort.
Yeah, I'm going to go by way of shameless plug for myself. I'm going to go to my next question. We're hosting a lung cancer summit in 2 weeks in Toronto, and bringing together a bunch of national leaders to come up with an action plan for lung cancer, for which we're then going to go and advocate for money, which will hopefully flow to all of you people out there. But I'm going to go to the panel, you know, in the last dying minutes. You each get about a minute. As we look to the future, can you think of an actionable step that we can take on to sort of try to bend this curve? And in particular, you know, what people who are listening or will listen to this can do in their home community. So actionable step, what people can do for themselves. I'm going to go down the line. Anybody want to jump in first?
Yeah, I'm going to reiterate the advocacy. If you're a patient, family member, anyone interested in lung cancer screening or lung cancer care, talk to your MLA. talk to your healthcare leaders, talk to your premier, talk to your health minister, send them letters, harass them. Well, maybe not harass them, that's the wrong term. Harass them with letters is what I meant. And you know, people reply, you know, I mean, it's amazing. We've had small letter writing campaigns in Alberta, and, you know, a week later, I get all these requests from the administrators. How do we reply to these letters? So they do help move things along.
Dr. Martel, do you want to build on that? Do you have an
Yeah,
actionable step?
I would say, yeah, we have to talk to the politicians, to the Ministry of Health, of course. I gave a talk to the politician in September, and just, in fact, we should compare. I don't want to take something from no one else, but in breast cancer, they just went up to 74 years old for the screening, and they're discussing going down to 40 years old. Of course, it might be okay, but we still don't have an official program for lung cancer screening. So we have to tell them that lung cancer is a very important disease, and that we should screen, and that it will help to save lives. So it's on the end of the I would say, to the Ministry of Health and politicians, so advocacy, like I said. I would say that for Quebec, when the CPAC launched his program with the funding, this was very helpful to start, because there was a deadline, and we have to apply for the funding, and this was very helpful because if you remind, it was in the spring of 2020, just after the first wave of pandemic. So if the CPAC hasn't bring this program, we wouldn't start in the 2021. So in fact, this is something helpful with a program, with a deadline and funding. This can bring the politicians to say, okay, let's jump in.
I worked so hard to get that into the strategy for CPAC, so I'm happy that the money actually made it to where it was supposed to. Dr. Lam, are you going to jump in next, or Dr. Liu? Who'd like to jump in next?
So I think we need to give patients hope. When people talk about lung cancer, they're still thinking that lung cancer is by and large not very treatable or curable. But I think things have changed. I see a lot of heavy smokers. They don't want to come in for screening because they think, well, I don't want to know, right? So I think we need to let them know that with early detection, we can treat them better with surgery. And even when they have a more advanced cancer, we have so many targeted therapy, immunotherapy that Dr. Jurgens are familiar with, and Dr. Liu. The patients are doing much better than before. I think we need to get this message out to people. When you get lung cancer, this is not a death sentence. There is hope. We can do so well right now compared to 10 or 20 years ago. So I think we need to portray lung cancer in a different way.
And I'm going to add to that, right? At the same time that we have to give people hope, this is the opportunity for us to also advocate that in order to make continued advances, whether it's in the screening side or on the treatment side, we need to have better funding for the research as well. Progress comes only with our ability to move forward in technology. We talk about AI and so forth. None of that can happen unless there is the research that occurs. And that's how you generate the data. That's how you convince politicians. That's how you give hope to patients and to families and so forth. So make sure you don't forget about that aspect as well.
Great. Well, thank you very much to the panelists. That's been a wonderful conversation in all of your presentations. I learned a lot today, and I always sort of, it's amazing how much I come away from these learning myself. So I appreciate all of your thoughtful presentations. And to all the audience there, I'm going to talk for a little bit longer, then I'm going to pass it off to Dr. Jurgens, who's got the last few minutes, and really say, I think today's been interesting. We've all learned a lot and discussed a lot. And sort of started to scratch at the surface of all the barriers that are in place from a societal level, from a stigma level, from an equity level that we're facing to get lung cancer screening to the people who need it. I think those calls to action that everybody reiterated about writing letters and being participatory is probably, you know, the central point here is that we need to be present and visible and advocate for this disease. But you know, like so many things in life, you have to do it collectively, and that individual sort of shouting by themselves probably won't get as far as everybody working together. And it's a what's the expression? If you want to go fast, go do it alone. If you want to go far, go together. So I think we're gonna have to go together to take this the distance. So I encourage you all to continue this dialogue closer to home and with your communities, and please reach out to Lung Cancer Canada or any of us here if you have further questions. Because I think that lung cancer screening, we're at a tipping point. I think it's going to be there across the country, and we're just going to have to keep pushing to get that last bit of the distance. So it's my pleasure now to introduce Dr. Roz Juergens for the closing remarks. She's a lead at Lung Cancer Canada's new approach to advocacy. And I look forward to hearing her thoughts as we wrap up this session. And I can say from a personal note, Dr. Juergens and I work in the same facility, and she's always been sort of doing things better than me. We were in the same leadership course, and we had to negotiate against each other, and I think I lost handily. So I will pass over to Dr. Juergens to close out the session.
So that's absolutely not true. You crushed me that day, and I still haven't forgiven you a decade later. He cheated, I'm telling you. He sought my weak spot and went for it. Still love you dearly, though. Christian, thank you so much for leading this session. I feel so privileged to be an import into Canada and to be working within a system where we have seen such an incredible collaboration across this country. We don't want to just do it, we want to do it right. And I remember when the original NLST came out and I sat on committees in the United States. And it wasn't about doing right by patients. It was about how much centers could make by offering cheap low-dose CTs to be able to get referrals to their respirologists and their surgical teams and their imaging and all this kind of stuff. So I really do appreciate how thoughtful Canada is being about this. And I do think that we're going to have a program that will be celebrated, not just here in Canada, but internationally. So thank you, Christian, for chairing. If we can get the next slide. Oh, there we go. I would like to thank our sponsors for today's event. So thank you to Amgen, AstraZeneca, Merck, and Pfizer. It was with their support that we were able to sponsor this webinar and bring this policy forum to you today. I really would like to thank all of our speakers today. I know how incredibly busy our healthcare professionals are, especially the ones that we have here today. So thank you to Dr. Lam, thank you to Dr. Martel, thank you, Dr. Tremblay, Dr. Liu, and again, Dr. Finley. I'd also like to thank the team at Lung Cancer Canada for tirelessly working to bring this together today. I just want to reiterate the urgent need for collaborative action. I think Christian said it very well, that us working on our own create a small noise, but together we can make a big noise. And, you know, I think of my lung cancer patients when I think about that. And I think about, you know, why are we not out there, you know, doing huge marches and things like that? And they can be done, and we're doing the Give a Breath walks. So watch for that this coming year and years to come. But many of our patients are, you know, using oxygen, and they have a hard enough time just getting from their living room to their washroom. So they're not out there pounding the pavement because their breath is precious. So it's really up to us, their physicians, their loved ones, their caregivers, to give them the voice that they might not otherwise have. Delayed and missed screenings can significantly impact patient outcomes. So we need to make sure that we take this on. And I'm thrilled with the work and, again, the uptake of return visits that we're seeing here in Canada. I also want to highlight Lung Cancer Canada is really becoming more involved in the advocacy space. So this is the first of 2 policy forums that we're going to be holding this year, and we're already planning our policy strategy for next year. So if there are topics that you'd like to see us cover in our advocacy series, please reach out to Lung Cancer Canada, and we're happy to take that under consideration. I also want to highlight some of the upcoming events. As many of you will know, November is Lung Cancer Awareness Month. We are really doing a huge blitz trying to make sure that the voice of lung cancer is heard. Our annual fundraising event, the Evening of Hope, is coming up this coming Sunday, November 17th. There is an in-person event in multiple locations across the country, so stretching from coast to coast, as well as a virtual option. So if you're interested in joining us, please, there's a link in the chat about the Evening of Hope. We also have been doing multiple lung cancer summits across the country. The upcoming one this month is actually out in Saskatoon. That's going to be coming next week on November 20th from 5 to 8 p.m. So if you know anyone out in the Saskatoon area, please encourage them to sign up for this event. Across the board, people have extolled us with how valuable they have felt their local events are. And if you're interested in hosting a local event, please reach out to us, and our team can connect and see if there's a possibility of getting an event closer to home. There's also some additional webinars that are coming. So there's a research webinar really looking at our Lung Ambition Awards. Our awardees this year have some incredible topics. One of them is looking at how we can augment lung cancer screening. So that is going to be held November 22nd from 12 to 1 p.m. virtually. I also highlighted that there's going to be a second policy forum. I'll be chairing this one. One of my passions is clinical trials, and we're going to talk about how we can do a better job of bringing trials to patients. So that's going to be held just after Lung Cancer Awareness Month finishes on December 5th from 12 to 3:30 p.m. Again, I want to give a shout out to some of the other wonderful things that exist on the Lung Cancer Canada website. We just revamped the Lung Cancer Canada website this year. So if you haven't visited us in a while, please come back and see our current website. There's tons of information out there aimed at everything from healthcare professionals to patients to caregivers to even policymakers. I think there's a ton of good evidence-based information that's found on the website. On there, you can see our hot off the press comprehensive guide to lung cancer. So this is a book that actually had input again from clinicians across the country, many of whom are on this webinar today. So this is something that you can either download, or at many of the cancer centers across the country, we've got paper copies available. If your center is not one that has these available, please let us know, and we're happy to reach out to the physicians there. We send them for free to the centers. We want any patient with lung cancer who wants access to good, credible information to be able to have access to this guide. We also, a few days ago, had our Faces of Lung Cancer report briefing. If you would like access to 2024's Faces of Lung Cancer report, it's also available on our website. We've highlighted multiple aspects of things, including screening, as well as clinical trials and a few other key items that are highlights of our advocacy this year. So I'm going to wrap up today's webinar. It is 3:30. Please, I want to encourage you guys to engage with Lung Cancer Canada. We don't want to do things without you. We want to do things with you as a group. I want to thank each and every one for their participation today. I know we can make a significant difference in the lives of our patients and caregivers affected by lung cancer in our community. So thanks everyone for their time today. And again, I look forward to seeing you at some more of our Lung Cancer Canada events later this month.